Welcome to Health and Veritas. I'm Harlan Krumholtz.
And I'm Howie Foreman. We're physicians and professors at Yale University. We're trying to get closer to the truth about health and healthcare. Ordinarily, we have a guest, but at least once a month, we're trying to do a deeper dive into a whole host of
I just
topics.
get you by myself. I
know,
happy.
And when we're actually physically in the studio, it makes a huge
Physically
difference.
in the studio, I get to see your beautiful face.
Exactly.
That's wonderful.
And we're both coordinated in our attire today in our polo shirts because it's 95 degrees outside.
It is hot.
So, and let me just say this for our listeners. You and I are both practically zealots about walking. Like, we like to walk everywhere. And so there's really not an option to come in dressed professionally if you're going to walk in between buildings on Yale's campus on a 95-degree day. So I do think this is professional attire. If you're going
Isn't there something, if you've been faculty for a certain number of years, then you no longer have to dress professionally?
I hope so.
Yeah, I hope so too.
Yeah. So, but I want to start off the podcast with a follow-up to last week. We talked about the Duchenne muscular dystrophy medication.
Yeah.
I mean, it's crazy.
Like usual, Howie, you're a week ahead of the...
No, but it's crazy to me that we have like huge follow-up. It's like such a fast news cycle that we even have a lot more. So a reminder, there were 3 deaths in 2 adolescents and 1 much older adult from an FDA-approved treatment.
Do we know how many people total have ever been treated with this? I mean, are those 3 out of how many?
Oh, I think I looked this up last time. I think it was something like 900 people or something.
So a large number of people have been treated. To me, that's a fairly robust number.
Yeah, or maybe even much more than that, but it's in that range at least. And the drug had received approval for total approval for like the 4 to 8-year-old ambulatory class, and then had received sort of an expedited approval in the more adult cases, but never full approval for those cases. And so you had these losses in the older cases. You had not had consequences in the younger cases. And all of a sudden, they take the drug off the market. The FDA recommends moving it off the market, and Sarepta goes ahead. And then there's even leaked anonymous words from the FDA saying it's going to be really hard to get it back on the market. And as you can imagine, the Duchenne muscular dystrophy community, parents mostly, were very, very upset with this. These people sign up in advance to be able to get it. It's scheduled months and months and months in advance. You're waiting for your child to get treated for this disease that you know is going to devastate them. And then it's pulled out from under them at that point. And so the thing that happens is after our podcast, just like a day after our podcast.
As soon as everyone heard it from
exactly.
us.
No, but after our podcast, the FDA does announce that there was an 8-year-old who had received this therapy and died. This is on Friday after our podcast. And that's like out of the blue. Nobody even talked about it. And maybe that was starting to explain why this whole thing happened. And then 3 days later, Monday, they announced the kid did not die related to the treatment at all. The FDA announces this. So that would have already been enough, like big news to come out that you're...
By the way, I just think that's weird. Usually it's like no matter what you die of, if it's in proximity to the time you've received one of these kinds of therapies, people will attribute it to
Absolutely.
that. So I'm really curious, did the person get hit by a car? What happened?
I've read the release. It says nothing. It doesn't say whether it was non-liver, because that's the big complication. It doesn't say anything. It doesn't say whether he got treated 3 years earlier. It doesn't say anything. But at least they say not related to the treatment. What made this even more curious is right after they have that announcement, they also announced that the FDA is reversing course, and now they're going to allow deliveries of the drug for these children. So that was already a big thing. It was already really odd, the sequence of events. And then to put a crazy little bow on the whole circus, the FDA fired Vinay Prasad. And you and I briefly talked about this offline. He was functioning not only as the head of this agency that regulates this drug and many other drugs, he was also the FDA chief scientific officer, chief medical officer. To me, one of the things, the take-home message of this whole thing is that when you start losing faith in the institutions and the people at those institutions, it makes us think all of this is one big conspiracy. So why don't you take it?
Well, I don't want to preempt it because I think there are at least two major stories in here. One is about how the FDA is operating, the degree to which they're being transparent, how they're making decisions, how those decisions are based on science, and what do we know about them. And here's a situation where they turned left and they turned right, and there was a lot of external pressure on them. It was very confusing. I'm sure for those parents, it was anxiety-provoking.
Devastating.
I can understand the case actually on some sites, but I don't know all the data like that. We still it hasn't been shared exactly what's transpired. So it's hard. So that's I think, as you've suggested and you talked about last week, that's an enormous story. And then the end result is the person who's kind of in charge of that decision gets let go of the FDA.
Right.
There's another one, which is really, it's an Icarus story, someone who flies too close to the sun. It's a story of this remarkable chapter of Vinay Prasad at the FDA coming to a close. This is an outspoken critic. He became a smash mouth kind of persona in medicine, going after people. I told you, nasty, smart, brilliant.
Yep, same words I used. Yep, but incredibly right.
But and then in recent months, aligned himself very closely to RFK Jr. Was starting to write really, I think, almost obsequious pieces about, I was half expecting him to say, and he's a very handsome man.
Right, exactly.
Because he was clearly positioning himself for an important position. He ends up getting to head the Center for Biologics Evaluation and Research. Peter Marks, who a very distinguished regulator for many years, was forced out. Vinay Prasad, never having really any sort of record in regulation except to be a gadfly.
And never managed any organization before.
Started to come in, and his departure comes 3 months after his appointment. So then we say, how many Scaramucci's has Prasad made? He's made maybe 10.
Not even. Yeah, not even.
Scaramucci, the famous person who was appointed by Trump as the press secretary for a matter of weeks before it turned sour. Howie, tell me what this means. This is what was told. He has a desire not to be a distraction, and he wants to spend more time with his family.
And he also did not make his own statement at all at this point.
And he hasn't said anything official.
Yeah.
So this is one of those stories where science, politics, and personality all collide. And, I think it's about him taking a hard line on certain evidence. He had redefined the sort of COVID vaccine. So I think talking about whether kids can get this. I mean, I just think it's...
And he had criticized Elevidus, or however it's pronounced.
That's Sarepta treatment.
Right.
Yep.
Before he even joined the FDA, he had criticized the decision by Peter Marks earlier, which, by the way, you could criticize it. We talked about that. It's not to say you couldn't criticize it, but it's not like they didn't already have him on record being against this.
So he'd come out full scale, MAGA, and then Laura Loomer comes after him.
Exactly.
And Rick Santorum
And let's
comes
just make
after
sure.
him.
So Rick Santorum is at least a former senator who, I don't know why this is an important topic for him, but this became an important topic for him. And you don't have to like Rick Santorum, but he at least has some standing in the world. Laura Loomer is a conspiracy theorist. I mean, that's the best way to describe her.
Influential.
Very influential.
Very influential.
Particularly with the president.
So this campaign starts. The Wall Street Journal has an editorial in which they called him a one-man death panel and a Bernie Sanders acolyte in Maha drag.
I love that line.
And I just want to say it's just hard to describe or overstate how surreal all this is. Here's someone who aligned himself with the administration's skepticism of pandemic-era public health, criticized child masking, booster shots for young people, and then he got painted as too authoritarian, too evidence-focused, even though, and then now left-leaning, and then next thing you know, gone. Oof.
No.
Oof.
And I think one important point for people to understand, though, is that in the midst of all of this are human beings being treated with drugs that almost require approval in certain situations, if there's even the most basic evidence that can support that. And here you have courageous families with young children, mostly boys, essentially all boys, who have been desperately waiting for this.
So there's that, I totally agree with you, but I'm also believe this brings in bright relief. Now the FDA is more political than ever.
Absolutely.
Whatever you think of Prasad, here was someone who, in a week, because of the backlash from the very strong MAGA people, the campaign against him is out. Completely. So what's the message to Macri, this commissioner of the FDA? I mean, you better toe the line, bend the knee. Right. But the question is, knee to what?
Right. In this case, this was not about MAGA or MAHA. This was about the fact that the more typical Republican line on drug therapies is evaluate safety and efficacy. If it crosses that bar, You approve it and you let doctors and their patients make decisions. And that is different than other people's views on it. There is more of a heavy regulatory hand view. And there's a view that says, and we can go back, you're an expert on this, on Vioxx. The view on Vioxx is a nuanced view, and I think you agree with that. Like, the problem with Vioxx was that Merck withheld data that could have informed people's decision-making. The decision about Vioxx was not a simple decision of dangerous drug never should have been on the market. You could have made the argument, I don't know whether you do or not, you could have made the argument that if we tell people that there's a significant risk of increased cardiovascular bad outcomes with Vioxx, but it works well in this situation, and if you're a doctor and you decide to prescribe it, you can go ahead and do that. You could have made that argument. There would be other people who said we should never approve a drug like that. And there is this range, and there are a lot of drugs like that.
No, and that reflected my opinion. My opinion wasn't whether it should be taken off the market. I was involved in the litigation on behalf of plaintiffs, but my position always was about transparency.
That's right.
People should be able to make informed choices. No data should be hidden. No data should be manipulated. It should be out there in the way it should.
No, and I 100% agree with you on that. And for our listeners, I mean, you are a very influential, important arbiter of this because of your, expertise in that. I mean, I fully support that, but I think a lot of people forget that Vioxx was not really a story about efficacy and safety per se.
And if anyone's forgot what Vioxx was, it was a non-steroidal COX-2 inhibitor that was meant to provide pain relief that was argued to be above and beyond what you get from like a Motrin, ibuprofen, and things like that. But in that, there was some controversy about that too.
That's right.
But anyway, lots in that FDA story, right? The Sarepta stuff, what's happened to Prasad, the politicization. What does it mean if they can mount a campaign within a week? And he is head of CBER, so all the biologics, and the chief medical officer.
And the chief scientific officer.
And the favored individual in the entire FDA of the commissioner. And he's gone.
It is. He'll have lots of stories to tell about this. I'm sure he'll weave it in his own way. But I think he's learned at least one lesson that, as they say, healthcare is not easy.
When I say what happens when the dogs catch the car, it's sometimes a little rockier than you expected. That was a good line. Yes. Yeah. All right. What else? What else you got?
So I want to go to something a little lighter. The CDC had two good stories this week. I'm going to hopefully cover both of them, but one of them was a light one, and that is the story on marijuana in canola oil. I'll explain more.
Marijuana in canola oil?
Yes.
Okay.
There was a case of mass THC, that's the active ingredient in marijuana, intoxication was reported from famous Yetis in a suburb of Madison, Wisconsin. 85 people, aged all the way up to 91 years of age, became intoxicated after eating at Famous Yetis. Famous Yetis is famous for their garlic bread, for their pizza, for their cheese bread, and their grinders. But now they're also famous for an unexpected but thankfully reversible adverse medical event. Quick-thinking physicians and the CDC solved this puzzle when numerous individuals showed up at emergency rooms after eating a meal at Famous Yetis with symptoms resembling marijuana or THC use. So how did this happen? Famous Yetis used a communal kitchen and borrowed some canola oil. And the CDC actually literally in their thing had a picture of the canola oil without realizing that it had been infused with THC on the way to making baked marijuana products in a legal dispensary. 28 people were seen in an emergency room. 3 were admitted overnight. A few others sought outpatient.
What were their symptoms?
Dizziness, sleepiness, and anxiety is what was written into the report. Yeah, not even...
And munchies, maybe munchies.
I guess so. Well, they just had Famous Yetis.
Yeah, right.
So the lesson here, though, is to know where you are sourcing your ingredients, obviously. And I only make light of this because the outcomes were really mostly fine.
Those are some smart epidemiologists, though.
I know. And the ER doctors, apparently. They're the ones, they first went in the homes and checked carbon monoxide levels because it simulated that.
But it was so many people.
And then they started to connect the dots. And I just want to point out, this could have been much more serious. Remember, these people literally ate a meal and basically got intoxicated, and a lot of them got in their cars and drove home. Wow. I mean, it could have been a problem, but luckily there wasn't one.
Wow. All right, well, you're on the light side. Let me go back to
heavy stuff.
It's kind of heavy. So I don't know if you've been reading about the NIH and what's going on with the pay line.
I need you to explain it more to me. I did read this morning about this.
So there's a funding storm brewing at the NIH. This has been going on for a long time, but it's starting to really hit hard. The NIH is slashing the number of research grants it funds. At some of the institutes, pay lines are dropping now to 4%. 4 out of 100 grants that come in are getting funded, 1 out of every 25. And, these are historically low rates. There were low rates for a long time. We've kind of drifted up as funding to the NIH got better, but this is, something, I think. And a new policy requiring NIH to fund multi-year grants up front rather than spending the payments across the 4 or 5 years. So that's depleting the number of actual new grants they can give out because they're not spreading it along. They're under some pressure to spend now because they've been spending slowly. But now instead of funding more grants and releasing them, they're funding some of these grants, the whole thing. And so get it again. You put in a 5-year grant, you used to get the money 1 year at a time. That meant you were funding a lot more grants than any given year with the expectation you could fund next year.
Right.
If you start saying, I'm going to write the whole check this year, then you're funding fewer grants this year with uncertainty about what the future is going to be. Lots of people are talking about this feeling fairly catastrophic for the research community and highly demoralizing. And look, I'm someone who applies for NIH grants, so I have some conflict here. But I do believe that the medical funding structure we have, as much as it can be improved, has produced the best science in the world. And it's been an engine of innovation. And now, with the way it's working now, it's getting a little crazy. And I'll tell you one other thing happened this week. So in the last cycle, I guess at least one person put in 20 grants, and the thought was this was AI assisted. By the way, I think AI should help you do grants. I mean, it can probably help you do better grants. But the NIH reacted to this by saying, we're going to start restricting the number of grants any one person can put in as a PI, as the principal investigator. So that's so wild. It's sort of like saying, well, our system is going to get overwhelmed. And instead of fixing the system, saying like, fine, bring it on. We'll screen them. We'll identify the good ones. Right. We don't care. It's like, okay, we're going to just start restricting the number of grants that people can put in. Is that going to net be positive? They say it's at 6 right now for a year. But how's that going to change? What's that going to affect? It's really kind of crazy. And, Congress hasn't intervened yet, and they're going to be debating now the appropriations bill while we're gone.
Apparently,
well, I guess they're on recess now, so when they get back in September.
Apparently, this is going to lead to billions of dollars of appropriated but unspent dollars that Congress could repurpose next year. And there is some real concern, I think, that this whole tactic is to just save money and to completely delay ever paying for things that we anticipated and Congress appropriated.
So when you put this together with the question of whether overhead's going to go down, the potential 40% cut that's being discussed by the administration for next year's NIH budget, then you've got our scientific community in a high level of uncertainty and about what's going to happen.
And any economist would tell you that if you're a student right now going to either college or even graduate school, you're changing the calculus around whether you go into academic research or not. I mean, there are a lot of places where smart people can go. If you make this a less productive place to be, we're not talking about getting rich. We're just talking about a productive place where you can guarantee getting a job. You're going to go into something else.
So lots of job freezes, hiring freezes.
Yep. So I'm going to come up with the other CDC story. It's a quick one, but it was a follow-up to something we've talked about a couple of years. Once again, we're learning about the perils of raw milk. We've just witnessed one of the largest outbreaks of raw milk-associated disease when 171 individuals, and the median age was 7, so it's majority children, were shown to have developed Salmonella typhimurium, which I'd never heard of.
I'm proud that you could pronounce it.
I'm not sure I'm pronouncing it correctly, but it is typhimurium.
Well, I want to salute the effort.
Thank you. Thank you. After presumably consuming raw milk or raw milk products such as cheese, this appeared to arise from one farm and led to 22 hospitalizations. No deaths were reported, so another sort of good outcome in the end. It all comes down to one cow, apparently, as I'll point out.
And how was it transmitted?
It was so the cow to the raw milk to either raw milk itself or to
You've been warning us about
cheese
raw milk for a long time.
But just to put this in context, there were 143 cases of raw milk enteric disease reported from 2009 to 2021 in California. This is 171 from one outbreak.
Wow.
So this is just a whole different level right now. And by the way, 171 cases we only know about because they reported them. Got to be many, many more people that had it and had sort of subclinical diagnosis. And as I said, they found the cow, they isolated the cow, the farm's back to being online producing raw milk. But I just want to remind people, like raw milk, which is unpasteurized milk, right, has risks. There are people who believe there are benefits. There is no significant evidence base to support the notion of real benefit from the raw milk. And here we have a strong example of risk. So I would just tell people be very, very cautious about raw milk products.
All right. So, I can't leave our last session of, this term. We're going to be on break after this. Yeah. So, of course, I got to go back to some AI stuff.
Yeah, no.
Yeah, okay. So ambient AI in healthcare, I've talked about this before. It's a sort of auto scribe. So they're listening to the doctors and the patients' conversations and then turning these into notes. Ultimately, they'll be doing decision support. There's another company that I haven't mentioned before, Ambience Healthcare, just raised $243 million in Series C funding, pushing its valuation to, wait for it, $1.25 billion. Howie, these are companies that were put together just in a very short period of time. There's all about algorithms. I'm not sure what the mode is. There's a bunch of them that are out there. Of course, at Yale, we're using a bridge. And it's a huge round. By the way, I always wondered, 243, how'd they settle on 243? But anyway, probably because of the way people are throwing money in. But this is one of the biggest of the years. Backers include Oak, which is from Connecticut.
Right, Ned Lamont's.
Annie Lamont's company.
Yep.
But also A16Z, OpenAI Startup Fund. And, this one is best known for its AI documentation tools. And, it's spreading quite a lot. They're in more than 40 health systems, including the Cleveland Clinic, UCSF, Houston Methodist. And Cleveland Clinic just signed a 5-year deal with them. And, it's just going to be very interesting to see what happens. That you've now got someone lurking in the room
always
with the doctor and patient.
And by the way, we haven't talked about it, and I have not tested it at all, but Doximity, which is the social media-based company for physicians that is publicly traded, is now offering a free version of their own AI.
That's so interesting.
That as long as you're not as part of a health system, you want to use it in your private office, it's free for you. I'd be very curious to know.
I wonder about the business model on that. You remember that in the pandemic, they did that for telemedicine. They immediately stood up a telemedicine program. Yeah. So that was kind of interesting too. And, it's going to give them access to a lot of data. And the question would be, what are they going to do with that data and how's that all going to work? It's going to be a big question.
I think that's exactly what they're aiming for. It's sort of a Tesla. If you listen to Elon Musk, he'll always tell you it's not about the cars, it's about the data. And maybe that is really what the mode is ultimately.
Well, I wanted to ask you about one more before we get on to another topic, which is, this company AI Doc, have you seen that?
That's what we use.
That's what I'm going to ask you about because it's also gaining a lot of momentum, doing raise, getting, popularity, moving really quickly. And I read Yale, New Haven, and it's primarily for radiology right now, but they're going to spread out. So what's your experience?
I've consistently had a good experience with them.
What happens? How does it work?
So we have, I don't know if we have 10 widgets, but we have widgets that will alert us when there is a pulmonary embolus in a pulmonary embolus CT. It'll also alert.
No, but what does does that mean that the AI, you've read it, now you've got all these scans in the repository at Yale, and this thing is crawling through the Yale database and then sending you a note to say, hey, we just discovered something over here. Is that what's happening?
Real time.
So you're in the ED. Somebody is coming in with a suspected blood clot in their lungs. They're getting a scan. You're reading the scan, and then what's happening?
It's giving you an alert saying, we think there's an intracranial bleed. We think there's a cervical spine fracture. So
is it flash up on your screen, or how does it work?
It effectively flashes on the screen. It's in the lower left corner.
And does it give you a percentage? There's a percentage chance, or it's just telling you, you should look closer?
Exactly. And it'll even give you a hot spot to look at if it's a big image.
Now, you're someone who wrote a really great paper several years ago that was where you had double read scans in the ED. So you're really an expert on quality and whether or not, the variability within the ED radiology readings and what people need to do. I thought that was a brilliant piece you wrote. It raised a really important question as to how much is being missed and would double reads for high consequence scans be important. Do you see this as the second read?
So there's no question it's an extra set of eyes. I've called it that many times when I've written review pieces about this. It is an extra set of eyes. And when you're in a reading room with residents, and maybe you had this experience when you read cardiac echoes, an extra set of eyes never hurts. I mean,
But is it forcing you to overread? Because now it's like getting you once it taps you on the shoulder and says, "What about this?" It's very hard for you to overturn that.
So
that's all called automation bias.
There are clearly people that are irritated by that, and I think depending on your level of confidence, it can fluster people at times.
How often will you overrule it?
Oh, more than half the time. Because for certain of the widgets, it's terrible. Like for an intracranial bleed, it's terrible because it's going to alert me about an intracranial bleed on someone who's having a follow-up scan from an intracranial bleed. I already knew it. It's going to take calcifications inside the brain and say it's a bleed. Not true. It's going to show me scar from previous surgery and say it's a bleed, and I'll say no. So there's a lot of that. The pulmonary embolus one is probably the most impressive one. That's the one where the false positives are relatively low and the true positives where I would have missed it.
And it's worth it to you.
To me, it's definitely worth it.
It's definitely worth it. And the other question I always wonder is the moat. So this is just really about, data and algorithms. And so can't anyone enter this market?
I think they can. I think the big thing with AI doc or ADOC as I think they call themselves now, is that they're non-intrusive. That's always been my phrase for it. It's their way of doing it and the alerts and everything like that is actually very effective. It does not make you feel like you're being...
And is it a closed loop system? And what I mean by that is that when you overrule it, it knows it because you're sharing data back with it. And so it's learning how to get better all the time?
If it is, it's doing that very poorly. And I say that advisedly. I don't want to insult the people at ADOC, but it has not gotten, in my opinion, it has gotten not materially better. Every time we've installed something, it's been good, and then it does not seem to get better. I'm one of the few people that will notify them about false positives, but I still don't see that going anywhere. I feel like it's going into a black box and they may or may not be using it. They're certainly not figuring out some very common false positives and just saying, gone, we don't have to look at these anymore. It doesn't happen. So I presume they will make some substantial improvements over time. If I have one criticism of them, it's that they have not materially improved after they install each widget.
So interesting the way it's all getting automated. There was one thing you told me a couple weeks ago that I thought was really, really interesting, which is that just the way radiology is going, there's that a lot of your colleagues are reading from home now. People aren't coming into the institution and they're just home. They're using these tools, but they're not actually on site anymore.
No. I don't know what percent it is, but if I had to guess, I'd bet a majority of our cases are being read remotely by our own people, but remotely in their homes. And certainly nationally, even more than that. If you look at job boards right now, people will not even take a pure on-site job anymore. Like the best they'll do is a hybrid on-site and a virtual job. And a lot of people are doing pure virtual jobs. I know of people who are taking a job in New Jersey,
and for everyone listening, we're talking about radiology. We're talking about
just
radiologists.
Yeah, radiologists. Yeah. But I mean, I know of people personally who literally with a straight face say, oh, I got a great job in New Jersey and I just bought a home off an island in Washington State. And I'm like, that.
And I told you, like, this is just so strange to me because when I grew up, we would huddle with the radiologists. I mean, we would have rich conversations. They would show us things. We would talk to them. We talked about the patients. And I just think some of this lost, let alone you had mentioned to me, what the residents' experience is.
I agree. I think I work on site personally 100%. I don't have a workstation at home. And I work with the residents. And I really enjoy the fact that the clinicians come back. I can tell you in the last week, at least 10 visits from colleagues, both in trauma surgery, emergency medicine, and from pediatric medicine, pediatric emergency medicine, come back with good questions, want to go over a case, just want to talk through a patient. I think it makes a material difference. I don't think it happens as easily virtually.
But for the workforce, you couldn't force people to come back now because it's just the market's not that.
Certainly not 100%. No way.
Yeah, that's interesting.
Yep.
All right, what else you got?
So it's the 60th anniversary of the signing of Medicare
I was
and Medicaid.
thinking that we should talk about that.
We should just at least mention it. I think it's good to remind people that, first of all, one thing I like to say in class, everybody is either already on Medicare or aspires to be at some point. So I think that's true. And Medicaid, of course, is the core of our healthcare safety net. And combined, the two programs directly cover roughly 40% of the population and indirectly touch every single one of us. So let's just hope that we can continue to improve these programs. That's been a core part of your career rather than dismantle or undermine them.
Isn't this really about the power of policy? I mean, look, it was a moment in time. Johnson's able to push the legislation through. It changed lives. I mean, it changed our healthcare system. It also caused some perversions in the healthcare system too, because it really doubled down all the fee-for-service.
It's far from perfect.
Far from perfect. But it did mean that if you were going to become 65, you in this country for the first time could know that you were going to be covered.
That's right. And we cover them reasonably well. I mean, particularly that we also have Medicaid, which means that those low-income Medicare beneficiaries actually get help with their deductibles and their copays and their premiums. We do a reasonably good job around the edges for a large number of people in the country, and we still leave too many behind.
So speaking of Medicare, I wanted to actually just finish this string of things I've been talking about over the last couple of weeks. I've talked about what's going on in the insurance industry and how things going. I talked about Elevance, and they had to readjust their expectations. Their stock dropped. Oscar, by the way, also had that. United Healthcare came out this week.
Yep.
And, this is the largest Medicare Advantage insurer in the country. And it's saying we're pulling out of this with their quarter 2 report. They're saying we're going to pull out of certain markets. That's going to impact maybe 600,000 beneficiaries. And, on this call that they had, the CEO now, Tim Knoll, said that their pricing assumptions were way off, and now they're predicting more than $6.5 billion additional medical costs than what they thought they were going to get for 2025, $6.5 billion more than they had calculated. They've got actuaries, they've got all these people. I mean, they've got highly sophisticated bean counters.
It's hard to predict this stuff. It just is.
Well, and then more than half of this excess cost is coming from Medicare Advantage.
Right.
So, where on one hand we're seeing in D.C., people are enamored of Medicare Advantage because they think they're going to be able to control the costs. But this year, at least, Medicare Advantage is becoming more difficult to handle. And I've also heard from some employers who are getting sticker shock. They're cutting into their margins. It's interrupting their businesses. I'm not seeing people write about this much, and I'm talking about you've got the self-insured, which are the large businesses, but these medium-sized businesses are being hit really hard with these increases. And then you've got towns, and who are trying to manage their budgets and having to raise taxes just to cover the increasing medical care costs. So I'm going to predict this year, this is all going to come to a head. This is going to be we're finally getting to a point where people are.
It may.
Well, especially if you make all these people uninsured too, it's going to be a lot of pressure on the system.
That'll happen a little bit later than this next year, but I'm with you. Look, we have not been able to fully explain why costs have been so high, both for hospitals as well as for the insurance companies this past year. We know some of it. The GLP-1s are a part of it. I mean, we have a much larger population now coming in for treatment. And by the way, even the GLP-1s are not simple anymore. Novo Nordisk stock went down by like 20% this week.
Reshuffling with a new CEO. And so forth,
and they're not doing as well as people. For a long time, they looked like a meme stock just going straight up in line. And even they have now come down considerably. So healthcare is hard, and I'm very cautious and humbled every year by what hits us on all different sides. Our hospital has still not gotten back on its feet in the same way it was before the pandemic. And I don't think anybody can precisely explain how that happened.
We need fresh new ideas. I really like, our friend Zeke Emanuel was writing about this and saying, of course, he's advocating for Democrats. Don't just call for people to be insured or roll back the big, beautiful bill. Think of, what do we need for the redesign? How is this going to look better in the future? And how can we address some of the shortfalls? Because it's far from perfect.
We can link in our show notes. It's a piece in the Bulwark where he really lays out specific ideas. And one of them is stop having people enroll 1 year at a time. Commit them to 5 years at a time so that insurance companies actually can make some types of strategic investments that have payoffs over a multi-year window, because we don't do that particularly well. And, quite frankly, I sit on the board of university health at Yale, and so I get to see how our Yale University Health Services functions, and they make very hard decisions all the time. And I think they do an extremely good job both balancing, holding down costs, but also being able to provide access to GLP-1s and other treatments as they emerge, no matter how expensive they are, including CRISPR technologies and other genetic treatments, gene treatments.
Yeah. No, Yale's kind of unique in this way. I mean, there's just a few like Yale, and it's that's cool that you're on the thing. So, Howie, we're at summer break. I just want to thank you again. What a pleasure it is to do this
fun.
with you. It's a real privilege. And for everyone out there, we thank you for listening. So let's just end. We'll do our final outro here.
And let me just say also, we have a great lineup for next year. I mean, I get a little.
We're going to hit escape velocity next year. Is that what you're saying?
I think we've already hit it. I mean, and let me just also say to the people out there, the number of people that have come up to me in the last few weeks by email or in person and have told me that they were excited about one or more episodes spontaneously without any reason to do it.
No,
really
I'm sending them money
me.
and I'm asking them.
Well, I appreciate that, Harlan. Someone has to do the marketing. But
Yeah.
I just want to say, like, it takes a village, by the way. I mean, we're going to thank Gloria and Tobias and Miranda again, and I thank you. But it is
Who knew it would grow to this? We get
4
it's nice.
years. We're going to have our 200th episode coming up in this next academic year.
And of course, for me, it's just selfish. I get to talk to you every week, so this is great.
Listen, you've always been like my big brother and my idol, and
Oh my
I'm
God!
so glad that I get to work
come
with
on!
you.
Like, you're the role model for all of us. So anyway, so you've been listening to Health and Veritas with Harlan Krumholtz and Howie Foreman.
So how did we do? To give us your feedback or to keep the conversation going, email us at health.veritas or follow us on any of social media.
And we love your feedback, especially your positive feedback.
Yeah, but we'll take
Please
negative
keep giving
feedback.
Howie positive feedback.
Yeah,
we love it.
I need it.
But rank us, rate us, helps people find us. We appreciate it.
And if you have questions about the MBA for Executives program at the Yale School of Management, reach out via email for more information or check out our website at som.yale.edu/EMBA.
Health and Veritas is sponsored by the Yale School of Management, the Yale School of Public Health. We are so grateful for them. And we're really lucky to be working with superstar undergraduates. Thanks to you, Howie. Thanks for your recruitment from your class, Tobias Liu and Gloria Beck. Tremendous, amazing. And we have a remarkable producer who somehow every week makes us sound better than we actually are, which we always appreciate.
And they are all joining us virtually or in person in the studio today, so we get to thank them in person.
And I get to work with the very best co-host of all time. Thank you so much, Howie. Talk to you soon.
Right back at you, Harlan. Thank you, Harlan. Talk to you soon.